All right, well, good evening, everyone, and welcome to the Lumbar Spine Research Society's webinar on outcome measures and predictive analytics, the future of spine surgery. My name is Jason Savage from the Cleveland Clinic, and I have the pleasure of co-moderating this session with my good friend and partner, Dr. Mike Steinmetz, Chairman of Neurosurgery at the clinic. Before we get started, I'd like to thank the LSRS Education Committee, and in particular, and special thanks to Katie Scheiffelbein for putting this together. Katie, we couldn't do this without you, so thank you. I'd also like to thank all the participants for tuning in. I hope you and your families are all safe and doing well during this COVID-19 pandemic. We have an absolutely outstanding faculty tonight, and I want to thank all of them for their willingness to participate. We have over 150 participants registered for the webinar, which is a great turnout, and it's definitely a testament to the outstanding faculty that we have. As the Research Society, we're constantly looking for better ways to evaluate our patients, both preoperatively and postoperatively. Tonight's webinar is going to dive into the future of outcome measures and how machine learning and predictive analytics are going to play a significant role in our field moving forward. We're going to have 3 talks in this webinar, followed by a panel discussion. We encourage you to submit your questions, and then Mike Steinmetz and I will kind of moderate that discussion after all 3 talks. So without further ado, I'd like to introduce our first speaker, Dr. Daryl Brockie from the University of Utah, who's going to give a talk on PROMIS versus legacy outcome measures in spine surgery.
Thanks, Jason. It's an honor to be part of this. I appreciate you all putting this together. So my charge is to talk about PROMIS in the age of outcomes. And as I get started here, I'll cover a number of topics, but before that, disclosures, I have nothing relevant really to this talk. To talk about PROMIS, to talk about outcomes, we really need to talk about value. And value means a lot of things to a lot of different people. It seems to be the word of the day in medicine. All eyes are on what we do and why we do it, and there have certainly been questions about the value of spine care. We need to really prove the value of spine care, but what's meant by value? And I'm sure all of you have seen this equation. Value is outcomes over cost. Essentially, what this means is that the higher the better the outcomes, the lower the cost, the better the value. And it's not just about cost, and it's not just about outcomes, but outcomes is a key piece to this. Well, what does that mean, really? Outcomes can be lots of different things. And so what I want to cover in the next 10 or so minutes is, what is the ideal measure of outcome? Is it a process measure like PQRS, or is it radiographs, or is it something coming from a patient? What's wrong with what we have? And then I'll cover what is PROMIS and does it work in spine surgery. So with that, I guess we need to focus on patient-reported outcome measures. PROMs or PROs have been around for a long time. In the last 20 years, the government has really focused on this, and this is from 23 years ago from Dr. Berwick at CMS saying that the ultimate measure and judge of the quality of medical effort is whether the patient has done well by the way they see their outcome. So patient-reported outcomes, even 25 years ago, was a hot topic. The FDA, Brennan, in 2006, said the patient properly queried is the best source of information. And even Michael Porter, who's kind of the rock star of the intersection of business and medicine, said the value should always be defined around the customer. So if we're talking about how the patient feels about outcomes, we should be asking them about their outcomes. But that's not so easy. The ideal patient-reported outcome measure is not what we have. It really is about minimal burden on the patient, and maybe also, I should say, minimal burden on the physician in the office. It should be easy to fill out, precise, reproducible, and maybe above all, not repetitive, which it so often is. We should have full coverage with covering, no ceiling effect or floor effect, and I'll cover a little bit about what that means. And we should be able to have it easily recognizable by the medical community, third-party payers, journal editors, and maybe most importantly by patients and by us. So there are a couple different kinds of patient-reported outcome measures. There's disease-specific measures, and there are lots of them, sort of an alphabet city, but the ones we're most familiar with are ODI and NDI. There are general outcome measures like the SF-36 or quality measures like EQ5D fall into this group. And then there's a sort of a newer category called domain-specific measures, which are really about domains of health. And before I get to those, which is really what PROMIS is about, let me just talk about what we have and what we do most frequently. And that's the ODI. The ODI is probably the most ubiquitous disease-specific outcome measure of maybe almost anything in medicine. It crosses dozens of languages. It covers many different diseases within a disease, meaning it was built for chronic low back pain, but is used for many things other than chronic low back pain, all related to spine disease. We took a look at it in some detail in the psychometrics of the ODI, and actually functions pretty well, I would say. We looked at 1,610 patients. This is now a while ago, but really wanted to understand where its weaknesses were, because its ease of use is pretty good. It's only 10 questions. It's easy to sort of score. You can do it without a computer. You can give it on paper. The value is high, but the problem is that there are some things that affect the ODI score. We all know that well, who use it a lot. One of those things is depression, and psychiatric or psychological illness can affect the score directly. Another problem that is maybe a little less apparent is that it has a floor effect. The floor of a disability index means low disability or no disability, but that floor incorporates 30% of the people that we gave it to in this 1,600 patients. So it's really hard you can't really tell the difference between those patients when the floor effect is so high. What does that mean? This is something called a person item map from our rash analysis or psychometric analysis, where the patients, all 1,600 of them, are on the upper part of this graph. And along the x-axis is standard deviations of more or less disability, and it's a bell curve around that. And underneath that is where the questions lie and where they test. And we can see this floor effect where about a third of the patients don't have a question to really differentiate them. We get different scores, but they're not really reliably different. The ceiling effect is much smaller, but nonetheless present. Some say this is the best we have in spine care for a disease-specific measure, and I think it probably is, actually, but we probably could do better, and that's where PROMIS comes from. PROMIS has been a now decade and a half effort, hundreds of millions of dollars invested, and built in a different style than the ODI and many of the outcome measures we talk about. It's built on item response theory, which I'll explain in a second, with better psychometrics. It is freely available to us. It was paid for by the NIH, but there is some cost to utilization, and is domain specific. What did I mean by domain? Well, this is the World Health Organization's domains of health: physical, mental, social health, and within those there's subdomains. And we're going to focus on physical function for the rest of this talk, although there are PROMIS measures that measure many of these other things. And in fact, when you say PROMIS, it's actually lots of different kinds of tests. So you can't just say, well, you can just say a PROMIS test, but it doesn't mean any one thing. It means the PROMIS group put them together, but there are lots of different measures within. And so I'm going to focus on the physical function test within the PROMIS group, but all of those different tests, whether you're measuring depression or pain or any of a number of other domains, has a common format. And that's this Likert style 5 answers to a question. Can you walk on flat ground, for example, without any difficulty, little, some, much, or unable to do? All the questions look somewhat like this. And so once you start answering them, they kind of flow. All of the patients are placed on a continuum of whatever you're testing, from 1 to 100. It's actually negative infinity to positive infinity in essence. It's just a continuum of that thing you're testing, like physical function or depression or whatever. And then a t-score is generated where the mean is 50 and one standard deviation is 10 points. So once you know sort of these rules, you know what the patient's score is. And if it's physical function and their score is 53, they're 3/10 of a standard deviation above the mean for the US in physical function. And if their depression score is 63, that means they're 1.3 standard deviations more depressed than the standard person in the country. So let's look at the physical function item bank. This is an item bank or a question bank. They call it questions items of 124 questions, at least the first version was. And you can interact with all the questions in the entire bank, which are placed along this continuum of function from bedridden to Olympic athlete or professional athlete, and everything in between. You can interact with all 124 and get very precisely on that line somewhere. Or you can use a short form version, 4, 8, 10, 12 questions, 20 questions, and be somewhat precisely or less precisely placed on there. Or you can use computer adaptive testing, which I'll again explain momentarily. But first, we wanted to validate the 124 question item bank in spine care, and we did that a while back. And unlike the ODI, we found a very small ceiling and floor effect and very small variance, and found the item bank in total to be much more appropriate for spine care. This is that person item map that I showed earlier, but turned sideways. So the patients are on the left and the questions are on the right, and the top and bottom questions are in boxes, and the few patients that fell outside those questions are above and below. But almost everybody falls within that range. So computer adaptive testing is a way to interact with this item bank of 124 questions and get the precision of 124 questions, but only ask 4 questions. And the way that works is the first question that's asked puts you somewhere on the map. And then the second question is focused right where you are and gets into more detail. And then based on your answer to that, the third question gives you more detail. And by the time you get to 4 or 5 questions, you have the precision of the entire 124 questions, but it took you less than a minute to answer this. We tested that out. We looked at the ODI versus the SF36 physical function domain versus the PROMIS PF-CAT. 10 questions for the ODI, 10 questions in the SF36. Most patients answered the PF-CAT in 4 questions. We again analyzed these, and this is how they look. Again, there's a separate 1,600 plus patients, and the ODI had 44% floor. I flipped it upside down so that high function and low disability are on the upper side of this map. So 44% of patients were uncovered by the highest functioning question in the ODI. The SF36 did much better at high function, but had 23% of the lower functioning patients uncovered by its lowest functioning question. And this is the PF-CAT, which had a much smaller ceiling and floor. You can see how many more patients are covered. In addition, looking specifically at precision, which is a different measure within the analysis, that dark line at 0.32 for standard error is sort of what most people think is good. So the ODI in blue doesn't quite reach that, but is okay in the light gray. The red, which is the SF36, does cross into the good range over a small range of the measure. This is 1 standard deviation clicks above and below the mean for the population of function. And then we can see the physical function CAT of PROMIS covers a much broader range of patients and much more precisely. It also happens to be faster to fill out. It took 49 seconds on average for those 1,600 patients versus ODI of taking nearly 3 minutes. So the PROMIS measure works well in the group that we tested, but we're not the only ones that have looked at this. Many have looked at this across all kinds of disease states within spine. This is Dr. Patel and the group out of Northwestern who looked at it in spinal stenosis, found it fit well for that group. This is a group out of Rush that looked at it for microdiscectomy. Another same group out of Rush looked at it in MIST lifts. This is a group out of Johns Hopkins looked at it in adult deformity, and a group out of the University of Utah looked at it in pediatric deformity. All found that it performed at least as well, if not better, than the disease-specific measures within spine. So in conclusion, the Ideal PRO patient-reported outcome measure should be minimal burden, less than 5 minutes to fill out. And that means all the questions together, not just the physical function CAT, for example. Should be easy to collect and easy to understand. And ideally, if you want to use the CAT, you need to collect it electronically. Data is automatically sent to a database and immediately available for care. I want to put one plug in for engaging the patient in the process. You share scores with the patient, make it part of the patient care process. The culture of data collection and the culture of outcomes reporting becomes second nature to patient care. encourage patients to understand as well as physicians, and you can also identify new problems. It also helps with patient expectations, which really leads to patient satisfaction and another whole host of issues that we could talk about at some point. And I'm going to end on this concept of benchmarking. Patients want to know where they are and how they're doing after surgery. This is a mixture of 870 patients that had lumbar spine surgery, all timed at time zero there, 5,600 different measures collected over time. And we found that while patients started at a mean of under 36, they reached an MCID at about 7 to 8 months. And their ultimate improvement was 1.5 plus MCIDs at about a year. Now, this is lots of different kinds of patients and lots of different kinds of surgeries. You can imagine how much better this would be if they were focused on lots of patients in your age group, lots of patients with your problem that had your surgery. So as we collect more data, we can start to do that. And patients can be doing better or worse than expectations. And if they're doing worse, we can start to identify why they're doing worse. And if, when you're seeing to begin with, to have the conversation about surgery, they're doing better than where you expect patients to end up, you may have a different conversation with that. So using PROs at the point of care, not just to understand large populations, is particularly valuable. And with that, I think I'll end and let the next guys move on. Thank you so much.
All right, thanks, Daryl. That really set the stage, I think, perfectly in terms of, highlighting some of the limitations of our legacy measures, but also kind of showing some of the benefits of PROMIS. I think a lot of us have gone to PROMIS. I think PROMIS is a great outcomes tool, but I think we would all agree it's probably not perfect either. So our next speaker, Dr. Mraz, is gonna take it one step further. Tom's one of our partners at the Cleveland Clinic. And he has a particular interest in kind of looking at big data and machine learning and predictive analytics, and he's going to give a talk on artificial intelligence is the future of bending the value curve for the spine service line. Thanks, Tom.
Thank you, Jason. Okay. Well, thank you, everybody, for having me. It's great to give a webinar on this particular topic. We've gone through quite a journey here at the Cleveland Clinic over the past 4 or 5 years, and I'm just going to take you through that and kind of give my perspective on where the spine service line is and can be. Obviously, there's a lot of different models in spine across the country. Our model here at the Cleveland Clinic is much like Mayo and may be very dissimilar from other academic institutions, but I think the common themes are in fact common, and so I think it's easy to discuss amongst ourselves, and we'll find some similarities. I do have some disclosures. I have royalties from Stryker. I own stock options in a company called Pearl Diver. I'm on the board of NASS. I'm the CME chair for NASS, and I'm a deputy editor for the Spine Journal and the Global Spine Journal. This talk will give a very brief background of AI in healthcare. I'll try to give some descriptions of why it's important for spine, particularly the spine service line, and I'll also discuss the Cleveland Clinic spine experience. About 4 years ago, I was sitting in a Cleveland Clinic conference where Ginny Rometty from CEO, she was a CEO for IBM, I believe she still is, and she said something at that time that resonated with me. She said, data is the natural resource of the 21st century. And it happened at a time when we were in spine trying to think of different kinds of solutions using a lot of different data scientists. And so it resonated with me. And we find ourselves currently at a time unlike any other time in healthcare. Literally, we're on a horizon with such a brilliant exposure to different types of computing capacity that in the history of man and womankind we've never had. And this comes from Ray Kurzweil's book, The Singularity is Near, where he describes the exponential or nonlinear growth of computing capacity in the world. And you can clearly see within this century a very sharp uptick in the capacity, the power of computing. And in fact, if you compare your cell phone currently that you're having on your desktop or in your pocket, it's more powerful than all computers on Earth 50 years ago. And it's projected in the year 2045 that one computer is in fact going to exceed the cognitive capacity of all human brains on Earth combined, which is almost unimaginable. It's important to note that AI is much more than just machine learning. It's searching, it's planning, it's reasoning, it's proposition, all the things that we use in common apps on our phone current day. And learning, there's supervised, unsupervised, and reinforcement learning. And what the solution to the problem that we face in the spine service line that I'm going to talk about, it really takes into account all of these things. Not only can we predict who's going to get better with surgery and at what cost, but how do we integrate it in such a way that gives a nice value proposition, a nice product to the patient to improve their experience of the patients, but also to improve the provider's experience of still being a doctor. Healthcare and AI has really permeated everywhere in healthcare. Medical imaging and diagnostics, mental health, drug discovery, insights and risk management, research, wearables, etc. These are just some of the examples where we see solutions being brought to the market in healthcare that really are going to transform healthcare. And I would bet in 5 or 10 years, the way we practice medicine is going to look historical. Some of the things we do now, how we get patient-reported outcomes, how we engage in patients, how we diagnose, how we treat, all these things are going to be transformed. And so why is this important to the spine surgery service line? Well, there's $110 billion in direct costs. And if you factor in indirect costs, that's probably double that. And we've heard many politicians every time there's an election that certain costs are unsustainable. When it pertains to healthcare, this truly is unsustainable. We're talking about a spine, the spine organ in this country costs 110 billion annually. And if you think about it, there's a lot of heterogeneity. And part of the problem with that $110 billion spend is in fact the heterogeneity. This is just an example of 2 papers that we wrote. This came from a survey that we sent out nationally to neurosurgeons, orthopedic surgeons, a variety of different practices, private practice, hybrid practice, academic practices, young versus old, etc. And for recurrent lumbar disc herniation and lower back pain, we found that there was a 69% and a 75% rate of disagreement in how practicing spine surgeons would utilize resources and in fact treat their patients. And so it's a massive opportunity if you think about where you want to go, but it's a big problem if you think about where you currently are. And it becomes more apparent and much more of a problem when we think about what happened in 2013 when the ACA hit our clinical operations with $731 billion in cuts in Medicare fee-for-service cuts, which were spread out over 9 years and across a lot of different parts of our health system. Hospital payment cuts, direct fee-for-service cuts, etc. And it's unprecedented in the healthcare. We've never experienced anything like this, and it's affected everybody on this call, everybody practicing in the United States, whether in private practice, academic setting, a place like the Cleveland Clinic or Mayo Clinic. It affects everybody. And I think you'll probably, this slide may resonate with you, where we get rate cuts and reflexively, whether you're in private practice or you're in a big healthcare system and you're an employee, you're forced in one way or the other to do more. And you can see how you can get into this vicious cycle where you end up doing more. Health insurance plans, including commercial and governmental payers, will say, listen, we're not going to pay that. And they get together and they say, well, listen, collectively, we're not going to pay you more. And then reflexively, you have to figure out how you're going to make yourself financially whole as in a healthcare institution, but at the same time, how do you do a lot of other things you need to do, like maintain engagement? And so if you look at it a different way, this is the Cleveland Clinic going back to 2015, where we see decreased reimbursement rates and we have a fixed operating expense. And you look at our E&Ms and procedures, we reflexively increased the amount of work that we did. And clearly, this is not what Daryl was talking about. This is not value-based healthcare. This is just fee-for-service model where we had to maintain profitability. But you can imagine if you had 15 surgeons, you have another 15 medical spine providers and a very large spine service line, there's going to come a point where you have maximal amount of work. Docs are not going to spend 14 hours a day operating or 120 hours a week operating. So there's a tangible downrange negative impact of this sort of model where you get increased burnout, decreased profitability. It negatively impacts research, education, and innovation. If providers are burned out, they're not going to want to do these sorts of things. And so you have to innovate a new model or a new way of approaching healthcare. And if you look at it from a different perspective, if you took an example of a patient who's got an L4-5 spondylolisthesis, we know what these patients look like. They've got the typical MRI and X-ray findings. They all pretty much look the same clinically with buttock and leg pain of varying degrees. But the patients themselves come in a lot of different variants. We have the value-seeking baby boomer, the loyal, affluent care seeker, the disconnected user, the chronic care consumer, opioid users, psychosocial overlay patients, et cetera, et cetera. And then if you couple that with, say, 15 or so surgeons, as an example, in the Cleveland Clinic system, operating at 5 or 6 different hospitals, you can understand why then we get variable patient-reported outcomes. We have a big variation in costs, going back again to that $110 billion direct spend, and we get variable reimbursements. Not only are the commercial payers and the governmental payers very different, we get paid differently at the different hospitals based upon their code. And so we had to come up with a better solution on how we manage the spine service line in order to keep pace with what was happening in the healthcare. And if you look at those 3 items above the yellow and white, that poses a massive financial risk to payers. And what payers care about is the 18-month downrange financial exposure they have from the point of care. And that is why when it comes down to contract negotiations between healthcare systems and payers, there's always a tug of war. Each side is playing poker. Nobody wants to give up essentially anything. And so it's very difficult to come up with mutually beneficial contracts. And that's why we've seen year over year, essentially, a decrease in realization rates that have occurred in multiple different places. And there are many variables that play into this. There are high number of surgeons, high number of pathologies. I mean, you think about the number of surgeries that we do for common things, probably in excess of 50 different surgeries that all are coming at a different cost. There's a high number of surgical and non-surgical treatments. If you think about just the non-operative care, the resource utilization, high expenditures, again, thinking about that $110 billion spend. And we have a ton of patient-specific variables. And what the peer-reviewed medical literature has done a great job is using hypothesis-driven research. We've identified lots of different discrete variables that, in fact, do drive outcome in terms of how a patient perceives their outcome following any sort of treatment that we employ. And then finally, you can factor in fee for service. The ugly truth is people get paid for what they do. But if you couple that with the guidelines for operative intervention put forth by the orthopedic surgery boards and the neurosurgery boards, 6 weeks of non-operative care, failure of non-operative regimen, and intractable pain, well, you think about it and you think about the complexity of the patients that we see, the number of pathologies that we treat, and then the number of surgeons that we have out there and the number of surgeries that we're performing. These are very crude guidelines to dial in ideally what we really want for a patient. And I'll give you a prime example of what's happening and what's happened. So in our earlier work, we looked at our own performance, and this is just for lumbar laminectomy. And this is very telling. I will tell you right now, and I'm not biased, I am from the Cleveland Clinic and I have a lot of partners who I love, but there are no renegades here. There's nobody operating out beyond the bounds of our governing boards. And you can see though that the gray and black dots on that particular scatter plot are patients, okay? On the far left are the preoperative PROMIS scores, the physical health scores. And at the 3 other points in shaded boxes are various time points post-surgery. Now, if you were to design a healthcare system or a strategy to treat patients, you would want all of those patients clustered on their preoperative and postoperative outcome scores. But what we have for a very simple pathology, lumbar laminectomy, it's a shotgun blast. And so we're doing a very poor job in identifying patients who should have surgery. And as they progress from the time of surgery, after we've already operated on them, after we've already done whatever we are going to do on their spine, in fact, the spread on how they do postoperatively gets even worse. And so in 2015, we set out to develop and deploy an AI platform to transform our own spine service line. We wanted to improve outcomes, decrease costs, decrease heterogeneity in terms of how we as surgeons and medical spine doctors are treating patients, and then leverage that platform with payers for better mutually beneficial contracts. Not that we only wanted to make more money, because that's not the intent. We wanted to maintain the very core missions that are important to us: research, education, innovation, maintain staff engagement, job satisfaction. Those sorts of things are very, very important to everybody practicing medicine. And so schematically, what this looks like, we used a variety of different data repositories, including patient-reported outcomes, finance, and everything in the electronic medical records. Here at the Cleveland Clinic, we use Epic. We wanted to horizontally integrate the entire spine service line. And what I mean by that is that if we're operating and treating patients at 25 or so non-surgical places like the family health centers, et cetera, and we're operating another 6 different hospitals, we wanted to make sure that everybody was on the same page, and we wanted to automate our performance and homogenize and be able to predict how we're going to perform. And so we set out to develop a AI-like platform which would use predictive analytics to give us the total cost of care, really allow us to deliver on value-based healthcare in its true definition, allow us to partner with payers to truly execute on population health. It's very difficult to go into a shared risk model with a payer without understanding your own cost of care across your own service line. And so this was very important to us. We also wanted a platform that was going to allow us not only to predict who should and should not have surgery and by whom within our system, but also create a system that automates a lot of what we do. How do we automate patient checks? How do we develop more patient touch points following surgery, or any time point during the process of care that we deliver to a patient? Post-operatively, post-op day 1, how do we see if a patient's pain is out of through the roof? How can we prevent readmissions or visits to the operating to the emergency department, et cetera? But we also wanted to create a system that engages the patients more actively, automatically, to improve their own patient experience. In other words, we wanted to own the entire service line. We didn't want parallel service lines treating the same patient population, because we knew that was fraught with problems. It's fraught with not only competition within the same healthcare system, but it subtracts from the very fabric of what you're trying to accomplish, and that's homogenization of how we treat patients. That includes PM&R, pain management, therapy, spine surgery, but also taking into account in a very real way hospital costs and reimbursements. And through that, we should be able to understand our own service line, be able to homogenize our performance across the entire service line, guarantee an outcome to a patient, and also partner in unique ways with our payers. And this is our earlier work, in which we had an input layer along the top row there, a database layer, which included the spine database. So all of our data repositories were housed into one single Teradata server. We then developed a machine learning algorithm, and then the outcome layer, or the output that we wanted this device to have, or this platform to have, is whatever we want it to be. If it was going to be cost, reimbursement, or importantly, it was going to be patient-reported outcome, readmissions, mortality, et cetera. And this is what in part what I'm talking about. And I know Jason and Mike Steinmetz are incredibly smart people, much smarter than I will ever be. But I will tell you, when I'm sitting in a room with a patient and I'm trying to figure out, well, what about the studies that have been published over the past 10 years? There are discrete data points in the electronic medical record that I can't possibly reconcile in real time to figure out how, in combination, do they impact a patient's perception. Should I decide to operate it, for example, on that L4-5 spondylolisthesis? And what we found is by using machine learning and looking at lots of different variables. In fact, when we looked at the lumbar stenosis patients in our system, we included over 120 different variables. And in fact, what we found was that there were combinations of different variables. For example, BMI with hematocrit, with zip code, for whatever reason, resulted in various outcomes, and they were able to map more appropriately to the outcomes that we wanted, specifically speaking, the PHQ-9, the EQ-5D, and the low back pain level scores, and things like that. And so what machine learning in this particular early modeling that we experienced was that there were many different things in the electronic medical record, the discrete data points of each particular patient, when in combination, we were able to identify cohorts where that were very unique, and patients who performed differently and in ways that we would not have been able to predict just by using the same typical approach to patients that we usually take in a clinic setting preoperatively. And what we found from this particular exercise, that 50% of our patients in our healthcare system for lumbar stenosis didn't make their MCID. Again, we're all operating under the guidelines of the American Board of Orthopedic Surgery and Neurosurgery. And we also found that the charges and reimbursements varied highly. And a lot of that stuff was the preoperative workups, the resource utilization, days wait, length of stay in the hospital, very variable among our own surgeons. And so it provided an opportunity for us to homogenize how we approach patient care, how we can homogenize, how can we use resources appropriately, how can we take best practice. You know, Mike Steinmetz does a great job in a lot of his lumbar spine surgery. He's less expensive, he delivers great outcomes. And so we ask ourselves, well, what is Mike doing differently than what I'm doing? And I found myself to be a very expensive person. And when I saw the data, I was like, that can't be true. But when we looked at it more granularly, there is clearly opportunity for me to change as a surgeon to make me look more like Mike Steinmetz. Not that I'll ever be like Mike Steinmetz because he's so popular and excellent. I just can possibly fathom being like him. But I guess what I'm trying to say is that there's a lot of opportunity for us to evolve as spine surgeons to create the best model across the entire service line in terms of how we approach patients. And this is just an example of our earlier platform that allowed us in real time to predict how we would perform preoperatively on any particular patient. And we had a bunch of different parameters that we could analyze in real time in the preoperative visit, where we looked at readmissions, DVTs, payments, and any of our patient-reported outcomes. And based upon in real time, while the patient's sitting in our preclinical area, we can see if I typed in a CPT code for TLIF at L45 for that L45 spondylolisthesis, I'll be able to determine whether or not in my hands, this particular patient with all the patient-specific variables that that patient presents to the Cleveland Clinic with is going to make his MCID for his patient-reported outcomes, at what cost. Or it may tell me that Dr. Savage is the best surgeon to operate on him, and not at the main campus. Maybe it's at one of the regional hospitals. And so this platform, once it's brought to deployment and fully deployed within the healthcare system, will allow us to make value-based decisions in real time. And so while we're preoperatively evaluating a patient, the platform will crunch all the data, including the financial records, the patient-specific data, the preoperative patient-reported outcomes, et cetera, and it'll allow us to make meaningful clinical decisions in real time. And we may find that a patient's, my plan for a particular patient is valuable. It may in turn say that this patient should not have surgery and we should choose another care path. And it may say that this patient should not have any sort of surgery and requires a completely different care path. Where we struggle at right now is to try to figure out, well, what about a specific patient? When we get our yellow or a red screen in Epic stating that we should not operate on this particular patient, what machine learning and what our current platform does not do for us, it doesn't tell us why or what specifically about a patient takes him out of running for surgery, or maybe an injection for that matter. And so there's some work for us to do, but I still think that this is probably a good way to move forward. I think in 2021, we'll achieve a more deliberate automation in concierge medicine. And this is a schematic of what we're trying to intend to do, where we have a data resource right here, including financial outcomes and everything in EMR. It's relegated and reconciled by the AI platform. It doesn't supplant the physician-patient interaction. It only enhances it. And then, but this AI platform is much more than that. It'll allow us, again, more patient-specific touch points. We're able to automate appointments, give them more points of access into the healthcare system, patient checks post-operatively and even pre-operatively, automatic image review, but also automate a lot of what we do with human beings today, pharmacy prescriptions, PT and OT prescriptions and follow-up, home nursing, et cetera. And all of this sort of thing would be relegated by the platform, and physicians can be, and we can program into that platform in real time, what are the thresholds by which a physician or an extender can be notified should a patient be having a problem. And so I think in a nutshell, I think the future for spine service line, but also for healthcare, is very bright. There's a lot that we're going to be experiencing over the next 5 to 10 years in terms of what we automate and how we diagnose and how we treat patients. And so from my perspective, in year 2020, I think it's a very exciting time to be a physician and specifically a spine surgeon. So with that, I'm going to end. Thank you for your time. It was a pleasure for me to talk to you tonight.
That was a great talk. I just want to say you have some phenomenal partners at Cleveland Clinic. I know, it's amazing. I just want to point that out. So, hey, a wonderful review of sort of the power of AI and predictive analytics and how it may be, useful in our practices moving forward and really change the paradigm of spine surgery and spine care. So our next speaker, I'm honored to introduce is Chris Ames, Dr. Chris Ames from UCSF. He is the director of spinal deformity and the spine tumor program, and is the co-director of spine surgery in UCSF at UCSF Spine Center. He is an expert in a number of areas but really is a trailblazer with regards to using big data and actually using big data to actually change the practice of surgery, specifically adult deformity surgery. And so this will be, I think, an excellent way to kind of bring together everything we're talking about, really show the power of big data, predictive analytics, in actually modifying and changing how we actually practice medicine. So Chris, take it away.
Great, thanks, thanks, Mike. Can you guys hear me okay? I'm having some computer problems.
Chris, we can see your slides and hear you perfectly.
Okay, perfect. So yeah, I'm sorry my webcam's not working, but I'll spare you my haircut because I've been cutting my hair for myself for the past couple months, so you won't have to look at me. In the next 12 minutes or so, I'm going to talk about what we've been doing at UCSF and in the International Spine Study Group, trying to apply the power of big data to the analysis and sustainability of the adult deformity population. I always like to start out the talk with this because it actually contains a lot of the issues that we're facing. When we go to industry and they spend most of their money, we talk about how we can change the outcome of these patients, they're still focused on what they can easily monetize. And yet if we think about how much a polyaxial screw or the next generation polyaxial screw is really going to change the outcome of our patients, I think that that's probably quite limited. And yet, until we're able to figure out ways to monetize the AI software in this specific field, it's going to be difficult to work with industry to develop some of these tools. And the figure on the right is a chimera, and that's the way I kind of think about it, where it's the surgeon with the AI, the combination of that being where we're going in the future, making us smarter and not replacing the human physician interaction. This is a slide, and I don't bother reading all the details, but it's showing you the tremendous activity from a startup and development standpoint with AI. This is all the FDA approvals in healthcare over the last couple of years. And mostly it's focused in histology, radiology, but increasingly there are some AI softwares that have been approved in the realm of decision making. Why do we need this? I think some of the other speakers covered a bit of this, but we have about 32 million people in the US with some type of adult spinal deformity, and it's increasing all the time with our aging population. So whether or not we operate on all those people, we at least have to process them. The AI can help to inform us, especially given the fact that now, back in 2011, we had about $800 billion spent on musculoskeletal disease. Spinal deformity was $80 billion back then. And this is up against now increasing drains on the healthcare dollar, including dementia care with our aging population, and COVID, which has drained the coffers significantly. So we knew several years ago that a storm was coming into our realm. We wanted to try to apply the power of big data to this problem. One way, which has been popularized, is collective intelligence. And that's essentially a multidisciplinary panel with a tumor board to try to figure out who's going to have the lowest complication rate, to apply our limited dollars to those patients, thinking that that might lift population health by restricting care to those less likely to have a major complication. But unless you can simultaneously look at outcome and risk and integrate that calculus in real time, what we tend to do is eliminate the patients with higher complication rates. And the big problem with that is that those patients actually often have the greatest change in their CID. More frail patients actually improve the most. So we think some of the solution here is in big data. At my institution, we developed a frailty tool, which is a 40-point scoring system that we use to stratify the patient substrate data file. And then we use that in real time. This has been validated in 3 different large data sets, correlating to complication rates. And we use that in real time as a predictive review assistant. So rather than doing a family practice review assistant with billing, this is now completely integrated into our medical record. We click on spine frailty, and this comes up. The data has been entered by our MA, and we get immediately their frailty index, their risk of a major complication, and their risk of increased legal stay. It helps to inform the hospital census.
Hey, Chris, can you hear me okay? Hey,
Yeah.
we're having a hard time on the audio from the audience. I don't know if it's an internet connection thing or if maybe you're a little distance away from the microphone. I just wanted to check any way we could troubleshoot that if it's maybe a distance from the microphone.
Can you hear me now?
Yeah, that's better. That's better.
Okay, I'll lean a little farther forward.
Okay.
So one of the areas that we've been focusing on is to try to increasingly datafy the process a bit more, realizing that there's a lot we included in some of our models that helped us to predict, but we're probably missing quite a bit of things that we hadn't thought of when we initially constructed our database. So now we check grip strength, so we do objective measures of muscular health. We do a sit-to-stand test, we do a 4-meter walk. These are just some examples of that in the clinic, showing how we assess these patients. And we measure this. Some are significantly related to age, such as grip strength. You can see how that goes down. But look at the heterogeneity of grip strength, for example, in 70, 75 years. Look at the 4-meter walk. Now, there was no significant difference in 4-meter walk times among the different groups, but we saw, again, a significant amount of heterogeneity looking at this data variable. And very interestingly, we saw a statistically significant decrease in sit-to-stand times when we operate on these patients. So this is, again, a datafication of the patient, increasingly looking at musculoskeletal health in an objective way rather than the standard age of health. We also wanted to quantify their mental frailty. We looked at dementia, catastrophizing, Myers-Briggs. Interestingly, the top 3 personalities in the adult spinal deformity population were ISTJ, ISFJ, ESFJ. We're looking at this with respect to satisfaction with treatment. One of our newest areas that we're focusing on is chemical and genetic frailty. We have a large-scale study now started looking at telomere length, which is a measure of genetic age. We see that people age very differently. Some people have a greater physiologic reserve as they get older, and other people seem to be wearing down more. When we correlate telomere length to perioperative complication, we see that it's much more significant than, for example, standard measures of chronological age. We're in the process of comparing frailty. The other aspect that is sort of state-of-the-art work that we're doing is trying to datafy bone. So we do all these fusion procedures at great cost, and then for their success, we rely upon solid fusion, rock fracture, osteoporosis, positive vision, PJF. And yet we don't do any datafication of the bone itself. We just select the standard bone cocktail. And there have been papers published on new bone markers, for example, like this one, it's fine, showing bone turnover ratio related to osteoporosis. So we have started a study called OsteoIndex, where we're datafying the bone. You can see the variables here, and looking for it related to PJF, rod fracture, osteoporosis. Increasingly datafying all fields of the patient, and we datafy the operations. This index that helps us to correlate to blood loss and procedure, and then we use this basic index to educate anesthesia on what is like well, so they can potentially transfuse the patient a bit earlier, given the fact that they have a good estimate of what the ultimate blood loss will be. Now, in the last 5 minutes or so, I want to talk about how we're using predictive analytics. I showed you guys some scoring systems and some increase in data fields and new data fields that we're starting to collect. But what if we take this all together? It's been our approach in the International Spinal Study Group the last several years. If we look in the literature, we see that surgeons themselves are relatively poor at predicting this prior to surgery. There's no significant correlation between surgeon risk assessment and outcome or major complication rate, nor can surgeons predict outcome, like this study is looking at misfits. So we think tools would be helpful in helping surgeons decide on who to operate and potentially in the future what operations to do. So our group combined with the European group several years ago and made a large data registry that we've leveraged now to create some tools that I'll show you. One is an informed consent tool where we can essentially with high accuracy predict the major complication risk from right after surgery all the way up to 2 years. And you can see if you look at overall complication rates in the database, they range from 4% to 75%. So there's a tremendous amount of variability in the patient population. And being able to predict allows us to precisely tell the patient what we think their risk of reoperation is.
Hey, Chris, it's Mike again. Hey, we're still we're going really in and out on the audio, and I know we're almost running to the end here. And again, I'm not sure. Maybe it's a computer audio standpoint. And again, I know we're running short of time. I'm not sure if it's worth trying to call in maybe on your cell phone to the audio line versus just keep going. Like I said, we're having a hard time hearing you.
If you can text me the number, I will call in.
Katie, can you do that? I wonder if it's worth doing that. The information's so valuable, but we can't really hear that. Katie, are you able to do that or put it out on the chat line or something?
Yes, I will.
Okay.
Can you hear me? Should I continue or just wait or stop?
Chris, what you're doing right now sounds really good. What you just did is sounding good.
Okay. So we can predict risk at every point in the care continuum. And one of those areas that is really interesting for us is the time of discharge, where we can identify patients that are red level risk of readmission and apply follow-up care to that patient, touch back with that patient to keep them out of the emergency room. One of the things we saw using predictive analytics was that modifiable factors constituted a large part of what was correlated to the risk of major complication. Based upon that, we realized that if we optimize patients, we may be able to decrease the heterogeneity. And this is very similar to trying to polarize opinion on social media so that they can make your click-through more predictable. If you can optimize a patient's sit-to-stand times, for example, pre-op in physical therapy, and make them spend more of their day standing, then potentially we can decrease the major complication variability in this patient population. And this is why we started a large-scale, fully datafied prehab program at my institution, where we datafy this entire process and optimize these patients across all of these different domains prior to surgery. We see a tremendous heterogeneity in our outcomes. And when we quote a patient an average improvement after surgery, we see that that only represents about 5% of the patients. And so our goal was to develop a tool that would give patients a precise prediction of how they're likely to do in all the HRQOL instruments. And the utilization of this is going to be to try to optimize a patient's health curve over their lifetime. It will essentially inform us as to when we pull the trigger on interventions to maximize the area under their function curve. But to do that, we need a good idea of how much a surgical intervention will improve them. So we've constructed a risk predictor based on 75 different variables for each of their outcomes domains, SRS-22, ODI, etc. This is what our output looks like. We can predict ODI and MCID, overall SRS-22, SRS-22, MCID. And maybe I'll finish here, especially since we're having audio problems, so we have time to talk after. But this is potentially, to me, the most interesting aspect of our data. We're essentially just like turning the computer loose to identify breast cancer based on unique patterns the machine learning identifies. We turn the machine loose on our data set and said, find patterns in our patient population and patterns in our procedures that we weren't aware of. If you look on the left of the screen, that's essentially how a surgeon sees their patient. And again, that's a fairly datafied patient already, but it can't compare to the way that the machine sees the patient, which is in real time based on 100 different variables, placing the patient in context of the entire data set. And what that allows you to do is identify the nearest neighbors in real time, immediately, at the time of surgery, prior to surgery, and say, this is how this patient did, this is how this one did. We just don't have the ability using human intelligence to recall those patients that were most similar based on 50 to 100 different variables. And this has allowed us to build a new classification of disease for adult spinal deformity based on AI modeling. It shows us clearly the patients that have the highest complication rate also had the greatest magnitude of clinical improvement. And I'll just finish with one case. This is how we process these patients now in our clinic. We fully measure them, obviously. We do their HRQL assessment. We compute their real-time frailty score and increased risk of major complication and stay. We place the patient in a nearest neighbor analysis, generating patients that are most like them and look at their operative outcomes. And then we enter their data in our risk predictors. And this takes about 20 minutes. It's still kind of cumbersome in terms of the length of time and the resource expenditure that you need to do this, but we're optimizing it, trying to make it faster. We can compute the risk of major complication, reoperation, readmission, outcomes that I showed you across each domain. And we use custom planning, we use precision custom rods for these patients to eliminate variability and alignment. It's all about decreasing variability, and then the final outcome. So maybe I'll stop there. I know it's been hard to hear me. Hopefully the slides conveyed some of the message, and I appreciate the opportunity to share around with you guys.
Chris, thank you so much. I mean, what a great talk. I mean, I think it just really shows the power of access to that kind of data and computing power to analyze it and what you can do with it moving forward. I just apologize to the group. We had a lot of problem with the audio. It kind of came in good for a while and then faded there, and so apologize to the group for that. So we have a little bit of time left. We're running right on the hour, and I think what we want to do is open up for some questions to the group through the chat line, and I'm going to go ahead and kick this off and just sort of ask a question to Daryl, in a sense that, I mean, I think we all look at PROMIS as the future for PORs, et cetera, moving forward, but a lot of us have invested significantly in historical data, ODI, SF36. Is there an effective crosswalk today for this? Can we just go right to PROMIS and keep using our historical data?
Thanks, Mike. Yeah, there are crosswalks for legacy outcome measures, particularly the ones you mentioned. So we can move over to the other. The challenges are unmet, though, with old data in ODI or SF36 that I showed in that outcome evaluation, that paper that I wrote. So while we can use it, and certainly we can move over, I think there's value in just getting started on the PROMIS measures. The value PROMIS measures really come partly through the focus and coverage of the measure, but partly really it's about understanding function or understanding pain or understanding the domain that the patient is concerned with across orthopedic, neurosurgical, spine, medicine, patient care issues. So while there's value in understanding how our patients are doing in spine, there's also value in sort of like what an SF36 does in understanding how they do compared to other problems that patients experience. And it turns out the patients in the spine realm, just like in SF36, are really debilitated. And we can make a huge impact on them. And we can show that across outcome measures by those that measure function and domains of health rather than those that are specific to a certain disease like chronic low back pain.
Hey, Tom, I've got a question for you from the panel, and I think it's a pretty good one. It says, how would you see managing the AI output suggesting a different surgeon for your surgical patient, right? So I think what you're looking at is fascinating, and obviously we're doing a lot of that work in Cleveland. But what happens if, we put it through this program and it says, well, Jason Savage shouldn't do that surgery, Mike Steinmetz should do it at such and such location. Like, where do you see that going?
Yeah, that came up.
The computer's wrong.
That's right.
So the way we're developing this is we hired a company called Insight. Insight has a lot of expertise in with machine learning and deep learning, but also bringing products like that to production, and so getting you a usable product. And during our working sessions with them before we started the project, that question came up. And I think it comes down to two things. Number one, we have to understand that this is going to be valid or not. If it's valid and the data is real, for example, if Jason, you or Mike perform better at lumbar surgery or whatever surgery that we're talking about than I do, then I just have to come to terms with it if in fact the data is real, right? I mean, that is imperative for every type of surgeon. I mean, if there's a way that you can get better, then you need to get better. But if it's telling me that, listen, out of 1,000 patients, Jason Savage does better than Tom Mraz does, then I'll acquiesce and say, listen, do the case then. But I think, it will create problems though if you're in an environment where you're competing with another service line. For example, ortho and neuro, it wouldn't work as well. But if you have a combined system like ours, it would be somewhat embarrassing to me if I realized that I was a subpar performer. But at the same time, it'd be an opportunity for me to become more like you two stars. But I think, again, it comes down to, is it valid? Is it real data, and is it accurate? And it's an opportunity to improve. It's an opportunity, most importantly, to give the patient the best care that they deserve.
Can I ask a question real quick, Jason? Yeah. Of Tom. Tom, you mentioned in your talk about what might be termed a dismal number of patients that reached MCID and some of your outcome scores, and wondering if we can do better. And it made me wonder how you feel about the patient that doesn't reach MCID but comes in and says they're doing so much better than they were before surgery, and they feel better, and whatever thing you tested didn't meet some threshold you set, they'd absolutely feel like if the surgery was a success to them. So how do we reconcile those?
Yeah, absolutely. That's a great question. And I think how we approach patient-reported outcomes is, number one, it's very variable across the country. We published a paper with Mount Sinai, I think, a couple of years ago, where we looked at the number of patient-reported outcomes being used, and it's over 200. And so with the exception, there's probably 5 ones that we use commonly, and the MCIDs vary. And I agree with you, Daryl. I think there are different things that we can look at, though. If you look at patient dissatisfiers, it's recurrent trips back to the doctor's office, it's persistent pain, it's something called my chart messages, which is that message that we use in Epic. You have patients who habitually and perhaps inappropriately or appropriately use that system. And so I think as we move forward through this, we're looking at different variables that we can correlate to how a patient perceives their outcome. How many times do they have to come back for their post-operative visits? How many imaging studies are they getting? How many telephone calls are we manning or womaning? And how many my chart messages are we having? And I think there will, in the next 3 to 5 years, become apparent to us different ways in which we can measure a patient's outcome. But I agree with you. I mean, again, I think going back to one of my previous slides, I think what we do right now is going to be historical, and how we evaluate is in large part very crude, because as you know, patient-reported outcomes are, it's a stamp on a time point, and that time point may be influenced by I just got a divorce, I just filed bankruptcy. Oh, by the way, doc, hi, surgery was great. I still feel like shit, or I feel bad. And so they're not perfect measures, but it's what we have. But I think if you look at maybe the patient-reported outcomes and all the other stuff that I mentioned in concert, maybe that'll give us a better idea how a patient's really doing.
Yeah, thanks, Tom. So I think we'll do one more question and then wrap it up. Chris, we'll start with you and then maybe open it up to the panel. I love what you guys are doing at UCSF in terms of the sophisticated outcome measures you're looking at. The question, though, is that I think there's a lot of residents and fellows on the line and young surgeons. What would you recommend to them? Like, this is very overwhelming. I mean, I'm in practice 9 years now, and I'm still very overwhelmed in terms of what outcome measure to collect. What would you kind of recommend to them in terms of where do you start? How do you kind of get into, building a little bit more of a sophisticated kind of, analysis of this?
Yeah, it's a good question, because as you can tell, I mean, most of what we're doing is research, and we're trying to figure out what are the critical data points to collect. When you say outcome, I think what you're really suggesting is what data points should we collect and analyze on our patients that will help in that decision making. And one of the things we found that's quite significant is the baseline HRQOLs. So it's not just for being able to publish a paper, but the baseline HRQL, the baseline ODI, some measures of physical functioning like grip strength, and potentially in the near future, potentially genetic age. Things like that may really help us decide on whom to operate and how big an operation they're likely to tolerate. When we analyze, for example, our outcome prediction models, sagittal plane was nowhere in the top 10. And what was most impactful was actually where the patient started. So I think a lot of trainees especially don't realize that you're not just collecting HRQL to do a research paper. You're actually trying to figure out how disabled the patients are, and that's going to help you figure out, who to operate on. So even if you don't have the, all the risk calculators and outcome calculators, you can use frailty, which is readily available, and you can use the baseline HRQLs. And the rest of it, those of us at large research institutions, we'll sort out over the next 5 to 10 years, and probably most of them will drop away and not be significant.
Yeah, thanks, Chris. I think that's really good advice, and it makes complete sense to me. Tom or Daryl, any final kind of comments?
Go ahead.
I don't have any.
Yeah, I was going to say this is an excellent job, Jason and Mike. Thanks for putting this together. I think we're right in the midst of this data explosion, and both Tom and Chris's talks really displayed that. And hopefully there'll be an easier way for us to interact with that data in the future, and it'll be more automated. My talk, I think, was focused a bit also on bringing that data back to the patient. Mine was just on PROs. Obviously the others are on much more complex data than that. But no matter what we are doing with our data, it's really important for us to remember to bring it back to the patient level. Thanks a lot, guys. Really appreciate it.
Yeah, no, thanks everybody. Tom, Chris, Daryl, thanks a lot for obviously those outstanding talks. Thank you to everyone who joined us. Out of respect of everyone's time, we'll go ahead and end there, and have a good night.
Thank you, everybody.
Thanks, guys.
All right, have a good evening.